coronary calcium scan, who should be eligible and should be qualified to get this testing done. And I wanted to discuss this interesting case. I have 63-year-old woman with history of hypertension, hyperlipidemia, BMI of 29, lipoprotein A of 200, markedly elevated, and apoprotein B of 99, borderline high. Um, and I wanted to tell you why CAC scan is appropriate. So somebody, and according to American Heart Association and American College of Cardiology guidelines, CAC is scoring in adults age between 40 to 75 old with borderline or intermediate ASCVD risk when the decision about a statin therapy or additional lipid lowering therapy is uncertain. Now, this patient has several risk factors: age more than 60, hypertension, hyperlipidemia, elevated ApoB, very high lipoprotein A of 200, overweight. And her elevated lipoprotein A is particularly important because it is an independent risk factor for premature coronary artery disease, aortic stenosis, and ischemic stroke. Because CSA would change management. If the CSA score is 0, that means very low short-term risk. In that case, we just manage the patient with lifestyle and maybe start a statin, but this patient is not interested in statin. And so lifestyle changes and repeats the CT scan in 5 years. High lipoprotein A is not going to change with the lifestyle, but she also have high LDL. I'm going to talk about that in a moment. If the score is between 1 to 99, and that means there's definitely some plaque, and then in that case, maybe I'll be able to convince her to start moderate to high intensity statin because LDL goal becomes less than 70. But if the score is more than 100, CSA score and high risk, in that case, she has to consider statin and ezetimibe, blood pressure control. But of course, it ultimately depends on the patient what they want. If they are totally resistant to taking a statin, they carry the risk. But in case if CSA score is more than 300, 400, very high risk, it comes to then you treat the patient just like a secondary prevention and preventive cardiology. But this patient, okay, so let me discuss her lipid panel. So her total cholesterol is 235 and LDL-C is 135, HDL-C is 83, excellent. Triglyceride 102, ApoB 99. Although her LDL and HDL is excellent and triglycerides are normal, she still has an atherogenic profile because LDL is above the recommended goal, ApoB is elevated, reflecting increased numbers of atherogenic particles, and lipoprotein A is markedly elevated, which is a genetically determined risk factor independent of LDL and HDL. So high HDL does not negate the risk associated with elevated LDL and markedly elevated lipoprotein A. People have this misconception that they have high HDL and low HD. They have high HDL and high LDL, and they don't want to take a statin because they think that HDL is canceling the risk of high LDL. So question is, does she qualify for CSA scan? Yes, according to ACC and AHA prevention guideline, she's an excellent candidate because age is 63, hypertension, LDL 135, ApoB elevated, markedly elevated lipoprotein A of 200 nanomole per liter, no known ASCVD, no prior MI, stroke, PCI, CABG, right? So CSA scan would be really, really good for her. And she's not on high intensity statin therapy because she doesn't want to, right? If she would be willing to, then our goal would be to keep LDL below 70, ApoB below 90, below 80. And but if LDL is still high, then we can add ezetimibe or consider PCSK9 inhibitor if CSC is high or if overall ASCVD risk is high. Because PCSK9 inhibitor also lower lipoprotein A by 20 to 30%. In her case, her ASCVD score is about 5% because she's 63-year-old, female, white, total cholesterol 235, HDL 83, LDL 135, hypertension yes, diabetes no, smoking no, blood pressure problem is there. She has hypertension, she's on losartan, the problem with the ACSVD score is that it does not take into account the risk of lipoprotein A, ApoB, and the family history of premature ASCVD. So her calculated score is somewhere like a 5 to 7%. As 10-year ASCVD risk is about 5 to 7%. She's borderline category. But you have to understand that scoring does not include lipoprotein calculation and apoprotein calculation and coronary calcium score even. And according to 2018-19 cholesterol guideline, patient with borderline ASCVD score or risk of 5 to 7.5% who have risk enhancing factors should be considered for statin therapy, and CSC scoring is reasonable when treatment decision remains uncertain. And she has multiple risk enhancer, hypertension, high LDL of 135, ApoB elevation, markedly elevated lipoprotein A, and age more than 60 years. So CSC scan is really important, and insurance doesn't want to cover because they don't really look at the ApoB and lipoprotein A elevation as important risk enhancer because this is not a part of their calculation. Although her HDL is 83, which is excellent, very high HDL does not offset the risk from elevated lipoprotein A or LDL. And the thing is that markedly elevated lipoprotein A is one of the strongest inherited risk factor for premature atherosclerotic cardiovascular disease. Her calculated ASCVD risk is borderline 5 to 7%, but her true risk is really intermediate or higher because of the elevated lipoprotein A. This is exactly type of patient for whom CSC scoring is recommended to refine risk assessment and guide treatment intensity. I hope you agree with that.